podcast for undergraduate to teach undergraduate orthopedics, to make it as simple as possible. And in one of those podcasts, I have
recording in progress.
I have one of those podcasts. I have a topic of ankle fractures. Okay, so if you guys can listen, you can get it from your rep. I'll give you. Can I be allowed to share my content, because I want to teach you all the PowerPoint for now? Is that okay?
Okay, I'm already presenting. Are you able to see it?
I'm able to see it, but I'm going to teach without the PowerPoint.
No problem. So you'd like me to stop the
Stop
presentation?
for now. If I need you, I will let you
Yes.
know. Okay?
Okay, doctor. Yes, doctor.
That's fine. So you can see my screen, huh? Can you guys see my screen? Hello? Can you see my screen?
Sorry, I muted myself. It's plain white.
It's plain white. That's fine. I just wanted to know.
Yeah.
So now we are talking about foot and ankle injuries, okay? So what I want to do is my PowerPoint, you will use it, okay? But I want to teach you guys without a PowerPoint. All right. Okay. So there are a few things. So I want to go through ankle injuries. I want to go through Achilles tendon injuries. I want to go through ankle sprains. I want to go through maybe Pylon fractures. I want to go through maybe Lisfranc injuries. So this topic is way too wide. But I think I can teach you without PowerPoint. It just needs you guys to listen. There are many people leaving and there are many people joining. But okay, so number one, ankle fractures, okay? Ankle fractures. Now, this is how I teach undergraduate ankle fractures. Our target is 10 minutes. Now it is 11. So I have to finish by 12:21 for ankle fractures, okay? So ankle fractures, yes. You can divide ankle fractures into, there is a colloquial classification, which we look at ankle fractures and we say that it's unimalleolar, bimalleolar, trimalleolar. So uni, bi, and trimalleolar. Tri. Okay? So that's ankle fractures, okay? So, for you as an undergraduate, what you want to determine is, for you as a medical officer, what you want to determine is what ankle fractures are stable and which ones are not stable. So if you've got an ankle fracture which is unstable or which is stable, then you're going to refer this. You're going to treat them. If you have one which is unstable, you're going to refer. So if you have a fracture which is a unimalleolar fracture, is potentially stable. A bimalleolar fracture is unstable and a trimalleolar fracture is also unstable. So these two, you need to refer. Okay? Refer. Now, sorry. So if you have a unimalleolar fracture, potentially stable, so you may be able to manage it alone. So that's number one. Number two, we can have another classification of ankle fractures called the Weber's classification. It's going to be in my Weber's classification. And what Denise Weber said was, if you look at an ankle fracture, you're going to look at an ankle fracture like this. So that's the medial malleolus, and that's a fibula, that's the tibia there. And that is that's the tibia, that is the fibula, okay? And the syndesmosis is there. So what Weber came and he said is that if you're looking at ankle fractures, you can look at them as happening below the syndesmosis, at the syndesmosis, or above the syndesmosis. So any fracture that is below the syndesmosis, that fracture could be stable. You understand? Because the syndesmosis is not involved. Any fracture at the syndesmosis may be stable or unstable. And any fracture above the syndesmosis, that's unstable. Okay? So I've given you the second criteria of saying that if you've got, for example, a fracture, let's say that's unimalleolar, and below the syndesmosis, that fracture is what? That fracture is unstable. That fracture is stable, and therefore you can manage none of. Okay? If you have a fracture that is above the syndesmosis, it means the syndesmosis is torn. If the syndesmosis is torn, it's unstable, and therefore that needs operative fixation. If you have a fracture at the syndesmosis, it may or may not be torn. Okay? The third is shifted or it's not shifted. So I will illustrate this like this. Okay? So now, if you have an ankle fracture and you look at it, you look at the medial clear space. Okay? That's where usually you look. Okay? So you have an ankle fracture, and you have an ankle fracture. So this is the medial malleolus, and that is the lateral malleolus. And this is the talus. So you look at the talus, and let's say the talus looks like that. Okay? You can clearly see that the space here is increased. Okay? That's a clear space. All right, and your fracture is maybe even here, maybe a Weber B. Okay? If this fracture, if this space is increased, then it means that this ligament here must be torn. So it's unstable. Okay? So I've given you 3 criteria. Number 1, is it more than 1 malleolus? If it is more than 1 malleolus, then we say that this fracture is unstable. Yeah? So those ones you need to refer to an orthopedic surgeon. Number 2, yeah, is it a Weber A? If it is a Weber A, it is potentially stable. Weber B may or may not be stable. Weber C is unstable, and therefore it needs operative intervention. Because if it does not look displaced, with time it may displace. You understand? And number 3, you check for talus shape. If there's a talus shape, guys, this is not difficult to remember. It is pretty easy, pretty simple to remember. And that is how you look at ankle fractures in adults, okay? Those are the things that will determine whether it is stable or unstable. Of course, the other things, their ankle fractures are not all the same. So like, for example, sometimes you have a medial malleolus fracture alone, because you tell me, Dr. Oburu, that's fine with the lateral. What about the medial malleolus? If it is medial malleolus and displaced, then you leave it. If it is medial malleolus and displaced, it just simply means that, so if you have, for example, a fracture, that's a medial malleolus fracture, okay, and it is displaced there, sometimes the periosteum comes and it creeps in there. And therefore, you may need operative intervention. The reason you need operative intervention is because it may go into non-union. Okay, not so much even for stability, but it may go into non-union. And therefore, you need operative intervention. So that is how you look at ankle fractures. You look at whether it is stable or unstable. Now, don't forget there are some ankle fractures like a Maisonneuve fracture. A Maisonneuve fracture is a fracture of the medial side. But if you look laterally, you find that the fracture is at the fibula, and that's an unstable fracture. The reason it's unstable is the injury starts from the medial side. So the injury, it will start from the medial side, okay? And then it will go to the fibula. So you may have a fracture here, and then it goes to the fibula and travels all the way in the interosseous membrane and it gets fractured. So what do you do when you see an ankle fracture? So when you see an ankle fracture, it's very simple. Let's say you're dealing with the stable ones, because those ones you will manage, okay? You don't need to call Dr. Oburu to manage an orthopedic surgeon. So those ones, number 1, it's very easy. Number 1, you put them in a back slab. How long do you put them in a back slab? For 1 week, okay? After 1 week, change it to a cast, okay? And then how long do you do this? So at 1 week, you do an X-ray, okay? You do an X-ray, and the X-ray, you want to check for the position. You do not want to check for colors. I mean, there's no colors you will see at 1 week. Okay, then you see them again. Sometimes you may see them again at 2 weeks. Okay, when you see them again at 2 weeks, you just want to check for the position again. If it has not moved at 2 weeks, it's unlikely to move. Therefore, bring them back to the clinic at week 6. Okay, week 6. And when you bring them at week 6, you remove the cast. So remember, after 1 week, you change this back slab and you put a full cast. Okay? I don't know if that's clear. The back slab and you pull. If the fracture, it's none of your business really to manage a surgeon, and an orthopedic surgeon is going to fix it. All right, that is the management of fractures that are unstable. What will they do? Plates and screws. Sometimes somebody may ask you in the exam, rarely, what will you do here? And I will just say plates and screws. I don't think you need to know the details of what you need to do with regards to the fixation. Okay. I don't know if that is clear. That's
Yes,
all you
Doctor.
need to. What do you do at week 6? You know, at week 6, really, it is, at week 6, you remove the cast, cast off. It is healed. Okay, do you do an x-ray? You could do an x-ray, but it's healed anyway. In fact, I can tell you when I was a reg in the UK, we never used to do x-rays, week 6. Week 6, no x-rays, just used to remove the cast. Because it's healed. You're not looking so much for radiological union, you're looking for clinical union. All right. Is that clear? And I have actually 1 minute below my time that I said I will take. I will add one thing. Sometimes you get a foot which looks crazy. You know, you can get a foot which looks mad. You know, you get a foot and it looks like crazy. It looks, it's facing, I don't know where. Please, guys, please. So you don't do this. This is important. You don't look at this foot and say, my, this foot looks so bad. Let me do an x-ray and then I call Dr. Oburu. No. That's bad practice. Reduce the fracture. You can, even your grandmother can tell this book is broken. Reduce the fracture. After you reduce the fracture, what do? You reduce the fracture and then you send the patient for x-ray. All right, it may not be a perfect reduction. Then you call the doctor. But there's some x-rays that you should not see. No, sometimes you find an ankle fracture. I don't have the x-rays here, but you can find an ankle fracture very badly displaced. That x-ray should not have been seen with no splint. That's bad medicine. Okay. That is the ankle fractures. All right, in 10 minutes, actually. So I will take, now all of this in pictures and everything are in my PowerPoint presentation, but sometimes I like to explain it better because, you know, PowerPoint, you'll just be so distracted. You look at the PowerPoint, but now I've explained it to you. Any questions? At ankle fractures. No questions means you can hear me, you can't hear me.
Hey, Doc.
Yes.
Could you please repeat the fracture you were explaining that starts on the medial side and then goes to the other side, and it's an unstable fracture?
Maisonneuve. It's a French name. I probably cannot spell it properly. Maisonneuve, something like that. If you Google, you'll find it. Unfortunately, I can't share my screen. Otherwise, I would have done it for you. Maisonneuve. Fracture. It's unstable. Okay. Any other question about ankle fractures? Okay. All right. Can I proceed?
Yes, doctor, please.
Number 2, I want to talk about pylon fractures. Pylon fractures are a totally different animal, okay? So pylon fractures or plafond, they are fractures near the ankle, but they mainly involve the distal tibia. So for example, if you have that there, and then you have that, and then you have the fibula there, okay? Terrible. So a pylon fracture would involve this area, okay? And the focus is really the tibia. So you'll find fractures, and usually they go all the way to the joint. Sometimes they may be extraticular, but they go all the way to the joint. The problem with pylon fractures is, number one, their results are unpredictable. Number two, massive soft tissue problems. Number three is, so that's what you're fighting. You're really fighting those. And then number three, obviously, arthritis. That goes with the results being unpredictable. All right. So now, pylon fractures. Patient comes, pylon fracture. What do? Number one, so you need to put a fixator, an external fixator, and then you need to span them. So you put a fixator that comes all the way from the foot, all the way going up, it spans this region. And then you need to wait for about a week to 2 weeks for the swelling to go down. All right. And then after you wait for a week, 2 weeks for the swelling to go down, then you can go ahead and do what? Then you can go ahead and do the fixation. The fixation of which is above your pay grade, you will refer to an orthopedic surgeon who will do the fixation. So that in a nutshell is pylon fractures. You just have to be careful with pylon fractures because of the massive soft tissue problem. And also, they are quite complex. Therefore, they can get arthritis of the joint. So you want to get an orthopedic. That is pylon fractures. In a nutshell. Now, if you read about pylon fractures, you will see Shaput fractures, what, all those things. But I always tell the undergraduates who rotate in my unit that, hey, look here, you can't read everything. You need to leave some for the consultant, orthopedic surgeon, and you also need some for the foot and ankle surgeon. All right, is that clear? So in pylon fractures, there's something called span, scan, plan, and fix. So span is fixator, scan to see how it is, yeah, plan, and then do the fixation. In fact, it used to be scan, I think, span, plan, and fix. But I think that now people also, they span before they even scan sometimes, because, if it's all over the place, you need to at least stabilize. So that is the principle of managing pylon fractures. So you aim to fix it in about 2 weeks. Any questions about pylon fractures? Okay, you guys are still there?
Yes, I think we're okay, doctor. We can move on to the next fracture.
That's fine. No, the next one I want to talk about is ankle sprains. So ankle sprains, our patient comes, they have an injury of the ankle, they are quite tender in the ankle, but when you examine, you can't feel, there's something known as Ottawa rules, which I think are good. Ottawa rules will guide you. So if you don't feel like bony tenderness and whatnot, you find that ankle fractures, there's somebody came up with these rules in order to avoid doing too many x-rays on ankle fracture, okay? And so, yeah, Ottawa rules, they can guide you. The most important thing is you find that the patient has got no specific fracture, but the patient is still very tender. Remember, it's not only a fracture that signifies a bad injury. Even a ligamentous injury can be quite bad. And the sprain can be either grade 1, grade 2, grade 3, grade 3, Some of the fibers are just stretched, grade 2. Some fibers are torn in grade 3. They are completely torn. That is what it is. Usually, there are a number of ligaments that are involved, okay? Number one is the lateral complex, the lateral complex. So the lateral complex consists of the anterior ligament. Okay, this is the most common. Then it consists of the calcaneofibular ligament. And then I think even the posterior talofibular ligament, which is not mentioned much, but these two are mentioned quite a bit. All right. Pardon?
Sorry
Hello?
for the interruption.
Can I
Sorry.
proceed?
Yes, please proceed. Sorry.
Good, good, good. I thought somebody would ask me a question or something. So now, then you can have the syndesmotic complex, okay? So you can have, so that's number one. Number two, you can have syndesmotic complex. Complex, okay? That can also be injured, all right? So, and sometimes this is called a high ankle sprain. And you see in your presentation how you examine this and everything. And then number three, you can have the medial complex, which is really like the deltoid. You know, this medial one, to be honest with you, rarely injured, but I've seen some patients who only have medial ligaments. Now, how do you manage ankle sprains? The thing about this, about ankle sprains, is the management is non-operative. So it depends on how bad the sprain is. If the sprain is not too bad, what I usually do is I just tell the patient, look here, it's an ankle sprain. Just wear your normal shoes, go about your regular business, and it will be okay. If the sprain is quite severe, the patient cannot walk, finding it difficult, you've examined it, standard, then I put them in a boot, okay? So I put them in an air cast boot. And that's quite good, eh? But sometimes you don't have an air cast boot, or sometimes even an ankle brace, okay? Ankle brace. If you don't have that and the sprain is very, very bad, you can actually put these people on. You can actually put these people on a cast, okay? If it's not bad. I don't like cast because the problem with cast is that you can't take them off, you can't take a shower and everything. But hey, you know, if you're working in the middle of Homa Bay, and Homa Bay, no offense to it, it's proverbial, it's supposedly my home county. So that's why I like using it, lest I be accused. So if you don't have it, you just, you know, it's okay. What you do is you just put them in a cast. Now, how do you put them in a cast? Usually rest them for up 2 to 4 weeks, okay? Well, for 2 to 6 weeks, okay? 2 to 6 weeks, and see how it is. A number of them will do much better after that. After that, I just get them moving. I don't even put them particularly on physio usually. However, some will get chronic. I am not quite sure what percentage off the top of my head. If they do get chronic, then those ones you send them for physiotherapy. So somebody with an ankle sprain, it's been there for more than 12 weeks. Is still struggling. I take a history. Please, guys, always take a history. Don't just go with MRI findings. Okay, I take a history and blah blah blah. And if I take a history and I find that, hey, look here, it's still it's been going on for more than 3 months, and then sometimes they have instability. They feel like the ankle is giving way and things. Then those ones, what do? We manage them with physio. And it's not just physio moving the limb up and down, it's specific kind of physio. So the kind of physio that you will get is motion, strengthening, peroneal strengthening, and also proprioception. And this is important. So you will find that you're using things like a wobble board. Yeah. So sometimes I find that, you know, patients for physio and these physios, they just put hot and cold packs and all those things, and it doesn't help the patient. But in this targeted physio, you're able to avoid surgery. And most of the ones that I have seen, I have actually avoided surgery. Sometimes you cannot avoid surgery. For example, this week, I'm going to be operating on one patient who has tried non-operative treatment. It has failed. And I'm going to be doing a procedure known as a Brostrom Gold. Okay. Now that is only for injuries, chronic injuries. Okay. So that is, yeah. But most of the time you avoid, okay? Yeah, most of the time you can avoid any surgery. Okay. So that in a nutshell is ankle sprains. Shall I proceed?
Yes, doctor, please.
Good, excellent. I just need one guy who is at least the. Now, what is the next topic? Achilles tendon injuries. Huh? So Achilles tendon injuries. Now, Achilles tendon usually or 30 to 40.
Dr. Oburu.
And I'm sure that is.
Dr. Oburu, you're breaking
Yes.
off a bit. If you could begin the Achilles tendon injury
Oh,
again.
I'm breaking off a bit. Oh,
Yeah, we didn't hear you.
Have is the Wi-Fi. I just hope the Wi-Fi is going to be okay. Can you hear me now?
Yes, we can.
Can you? You can. Okay. Yeah, my Wi-Fi, I just pray to God it behaves. Sometimes it can misbehave. I'm actually at the office. So Achilles tendon. So Achilles tendon, I said it's usually. Is that okay, guys?
Yes, doctor, it's better.
That's fine. If there's any problem, just let me know. I have some bundles which I can switch to, but sometimes I don't trust those very well.
I'll let you know.
So
Thank
Achilles tendon, I said weekend warriors, ages 34 to 35 to 50 or 30 to 40 years of age, you know, and the characteristic histories, they were running, they felt somebody kicked them at the back of the heel, but there was no contact, and then they had a lot of pain, and they start limping or they even start falling. Okay, that's a typical history. So patient comes to the clinic, and sometimes you can easily mistake this with an ankle sprain, but be careful. Always examine. The way you examine them prone, and you can do, there is something known as a Simon's test. Simon's test, or there's something known as a Thompson. It's the same thing. And what you do is you tell the patient to lie prone, their legs are dangling, and then you squeeze the calf and you see if there's any plantar flexion. If there's no plantar flexion, then Achilles tendon is torn. And obviously also you have to check for a gap. You palpate the chest, you may see a gap, okay? You may also check for plantar flexion strength. But a gap and a positive Simmons, that's a sign that the Achilles is torn. So how do you manage this? You know, there are two ways of managing Achilles tendon injury. There is operative and non-operative. And to be honest with you, you know, 70% of my work is general orthopedics, but 35% of my work is foot and ankle surgery. When I see these patients acutely, I don't always tell them they need surgery. I tell them, look here, this option can be managed operatively or non-operatively. Acute management, though, there is something known as a boot and wedges. So you can put an air cast boot and then the wedges. And the wedges are, you put them in the boot, okay? So they're wedges, and you keep on reducing them, okay? So you keep on reducing, so you remove that after 2 weeks, that after 2 weeks. And they can even weight bear on them. But there was a study in Canada that showed that this is not necessarily the case. That you can also manage them non-operatively. In the past also, the management was putting on a cast weeks, but guys have shown that this doesn't work. So you can use this at least, okay, in an air cast. But if the wedges are not available, all you can do is you can also put the patient in plantar flexion, okay, and see them in 2 weeks and reduce the plantar flexion. And you keep on reducing the plantar flexion, okay? Weeks, okay? So that is the management standard. If they are not, if you, the other option is surgery. In this town, I don't know, 90% of surgeons say no, okay, and the patient decides. The management of, if you don't manage this properly, or acutely, if you acutely Achilles tendon injury, and that's a big problem. Okay, neglected Achilles tendon injury is a matter. Surgery is not easy. The surgery is. Last week I did one with this gentleman who came from a wedding. He was from Congo, and I examined. I said, "Look here, Achilles tendon surgery on him." Okay, and the surgery is usually a flex transfer. Flexor loses long as transfer. Many other surgeries. So please don't miss the acute injury, because if you miss the chronic acute one, the rest are really, really difficult. All right. Is that fair?
Yes,
are you
doctor.
guys still with me?
Yes.
Good. Excellent. Now, so we've done ankle fractures, we've done pylon fractures, we've done ankle sprains, we have done Achilles tendon injuries, and now we have other injuries. Okay, so you can have, what else can you have? You can have a fracture of the talus, okay? Then you can have a fracture of the calcaneus. So what about talus fracture? So any joint injury, always remember in orthopedics, any injury that's the joint, near the joint, you want anatomic reduction, rigid fixation, and early mobilization, okay? Anatomic reduction, rigid fixation, and early mobilization, okay? That's critical with any injury that involves a joint. All right, so when you get a patient with talus fractures or calcaneus fractures, really as a medical officer, I think you should refer these patients, okay? But before you refer them, you know, you could ask them to get a CT scan. Really, no need of doing an MRI scan. So do get a CT scan. A CT scan will tell us, please tell them not to do a 3D reconstruction. A 3D reconstruction sometimes is utterly useless. 3D, it's okay. If it's a 3D reconstruction is okay if you have, it's okay as an addition, but guys, it should not be the main thing. You know, I hate 3D reconstruction because sometimes they don't tell you anything. You understand? You want to see as many slices as possible. Put like it. It's your slides, the better. Okay. The more the slide, the better. So that is about talus fractures and calcaneus fractures. Talus fractures need to be managed, all right, by an orthopedic surgeon. They're going to do a CT scan and decide what way to do. Okay, what they will do, what they will not do. Okay, then guys, let's move on from the talus, and that we can have fractures involving the Lisfranc joint. Okay, so joint is the tarsal metatarsal joint. Okay, Lisfranc. Okay, so Lisfranc joint is a TMT joint. Okay, all right, the Lisfranc joint. So you have the first, second, and third tarsometatarsal joint, then you have the fourth and the fifth. Okay, usually they involve the first, the second, and the third tarsometatarsal joint. If you have a patient with an injury to the foot with massive swelling in the foot, then one of the things you could suspect is a Lisfranc injury. If you suspect a Lisfranc injury, what you could do is a CT scan. Okay, always remember, please, no 3D reconstruction. First, just do a CT scan. All right, that will give you information about the injury. Okay, Lisfranc injury is really referred to an orthopedic surgeon. If it's completely undisplaced, sometimes they may elect to manage them nano, but sometimes they do surgery. Okay, because if you don't manage them, they may end up with a mid-foot collapse, a flat foot, and also away of the midfoot, okay, which is technically difficult to treat. All right, so let's now move on. We are moving on. We are almost getting to the tip of the toes. So you can have also fractures of the fifth metatarsal. They are quite specific themselves. So you have the fifth metatarsal. So you can have fractures in the fifth metatarsal that are, that's the fifth metatarsal. Okay. So you can have fractures that are over here. And this is the fourth metatarsal. Sorry, my drawing is not very good. So you can have fractures that are here. These fractures are called pseudojones fractures. And these fractures, you can just manage them in a boot, a short boot, or a plaster shoe. Okay, and these fractures really, they will heal. Sometimes they don't heal. Usually they're not symptomatic. You leave them alone. And then there is something known as Jones fracture. A Jones fracture is here. And then there are fractures of the shaft. Now, the problem with these fractures, why they're special, is the blood supply is a bit precarious around of this region, like in the scaphoid. So sometimes these fractures go into non-union. So what do you do if a patient has a Jones fracture? You know, there are two types. A patient may have it acutely, and they may have a chronic one. So if it's acute, you know, you can treat them in a boot. I usually tell them to be non-weight bearing. I'm not sure if the teaching has changed for now. I tell them to be non-weight bearing, and it can be even 6 to 12 weeks, okay? Then, if it doesn't heal, then we see what to do. But you can have a chronic one. So a patient presents 5, 6 months, and those ones usually you'll find out. So those ones you need to fix those ones, okay? And then you can have fractures that are distal, fifth metatarsal. So those ones you can just leave with a boot. Generally, guys, fractures in the foot, usually, that you don't think fractures of the base of the metatarsal, unless it's a Lisfranc, you can just manage with a boot, okay? That's what I would say, manage with a boot. What about shaft fractures? Shaft fractures of the metatarsal, I usually manage them with a boot. Be careful though, sometimes you have fractures of the metatarsal head, and that's the metatarsal there. And you can have a fracture here. And what happens is that, like the patient I had many years ago, it comes and unites there. And then they feel like they're walking on pebbles. You don't want that. So please respect all fractures. Always remember that you may do an X-ray on the AP, but there is a lateral X-ray, okay? That is how I would manage. What about fractures of the phalanx? These are very common. These are among the most common. The most important thing with the foot is you want to see alignment, okay? Alignment of the toes. That is critical. You want to see what's the alignment of the toes. If the alignment of the toes is good, then you are all right, okay? The alignment of the toes is quite good, you are okay. All you need to do many a times is just to do body strapping. Body strapping of the toes, one to another. Okay, and because you just want to see if the alignment is important because of footwear. Okay, and this is phalangeal fractures. So sometimes you just body strap them and they're fine. Even metatarsal fractures, you know, those ones, the alignment is okay. Many a times you just give them a boot. I like a boot because you can remove it to shower and things, all right? Phalangeal fractures, no big deal. Yeah, your body strap them, especially if they are not, if the alignment is fine, because you want the alignment for the sake of wearing shoes. Okay, so those are whatever. Needless to say, if you have a dislocation of the toes, you need to reduce it so that you avoid arthritis of the toe. Okay, I think in a nutshell, that's our lesson for today. I try to explain. There are other details in the PowerPoint presentation. If you go, you will see. Some of the topics that I've given, like ankle fractures, ankle sprains, I have discussed in the podcast, so that if you want to refresh yourself, you can always do that. I'll try and see if soon I can do on Talus fractures and Calcaneus fractures and Lisfranc injuries. Just trying to make it as simple as possible. I think that's me done. I have shared my PowerPoint presentation, which is more or less what I've said, and you can have a look at it. Thank you very much.
Thank you, Dr. Oburu. I wanted to ask, did you share your podcast with the classroom?
I think I did, yeah. I think it was, I don't know who called me yesterday. Who was I speaking yesterday? Yes, no, I shared it with Lavin.
Yes.
So Lavin has.
Okay, so we will get the podcast.
Okay.
Yes, thank you for your time, Doctor.
Yeah. You can. I'm trying to. It has got a lot of other topics that I think are relevant to you guys. Yeah, hopefully it will be of use to you. Okay.
Thank you, Doctor. Yes, we have received it.
Thank you very much.
Okay.
No problem. Bye.
Have a good day, Doctor.
Good day.
Recording stopped.